Morning, everyone. Welcome to Grand Rounds. It is my honor today to welcome Dr. John Levine, Professor of Internal Medicine and Pediatrics, the Louis Alidort Clinical Research Professor of Hematology, and Director of the Bone Marrow Transplant Clinical Research here at the Icahn School of Medicine at Mount Sinai. He is a clinical investigator with a research focus on acute graft-versus-host disease, the primary lethal complication of allogeneic hematopoietic cell transplantation. Dr. Levine and his principal collaborators, Dr. James Ferrara, created the Mount Sinai Acute Graft-vs-Host Disease International Consortium, or MAGIC, a research collaboration and clinical trials network that includes 25 centers that prospectively collect clinical data and serum samples from hundreds of samples across the nation annually. Since his arrival at Mount Sinai in 2015, he has established the international guidelines using to stage and grade graft-versus-host disease, and co-invented a blood test that predicts graft-versus-host disease outcomes, can guide treatment, and is now commercially available and widely ordered at hospitals and clinics around the country. He's also developed biomarker-guided, risk-adapted clinical trials through MAGIC as well. We are lucky to have him speak with us today. Welcome.
Thank you for the invitation. Let me just share my screen. Oops. Everybody see that?
Looks good.
Okay, great. I'll just note that I was the one asked to give the talk, but I'm really presenting on behalf of both myself and Jamie Ferrara. We co-direct the MAGIC collaboration. I'm going to share a lot of the data that I'm going to share today was generated in Jamie's laboratory. And the title of today's talk is Translational Trials in GVHD from the MAGIC Consortium. I gave a talk about 2 years ago to this Grand Rounds where we discussed some of our plans. And today I get to tell some of the results from those plans that had been set in motion. Just starting with just the very basics of graft-versus-host disease, I think everybody should be reasonably familiar. Donor T cells from an allogeneic transplant donor recognize recipient tissue as foreign and they attack that tissue. GVHD is the leading cause of non-relapse mortality after an allogeneic transplant. High-dose steroids are the mainstay of treatment. There's about a 60 to 80% overall response rate. And the organ most resistant to steroid treatment is the GI tract. And in fact, steroid refractory GI GVHD accounts for the majority of GVHD deaths. Advances in treatment and outcomes require multi-center collaboration. And that's why we formed this MAGIC consortium. And this is just to give you a brief listing of the centers. This is both an adult and pediatric consortium that extends across North America, Europe, Asia, with some dedicated pediatric centers within the consortium. So what the MAGIC collaboration was able to generate is real-world data. So we have a natural history trial, rolls over 600 allogeneic patients per year, 24 centers. We collect serum when GVHD is treated in order to do biomarker assessments. And as was mentioned very nicely in the introduction, the MAGIC Consortium has led the way in terms of standardizing GVHD staging and grading among centers. We published the international guidance in 2016, and then has since been endorsed by the leading international groups as the standard, and it's been accepted by the FDA for determining response in clinical trials. We've also standardized data collection within MAGIC, and we have uniform adjudication so that regardless of where a patient is diagnosed and treated, the GVHD can be assessed uniformly. And this is really important for understanding variances in outcomes should be due to variances within the patient, not variances within how the doctor assessed the patient. And we record in this natural history trial, we record detailed clinical trajectories. And this real world data identifies actual practice. And we've unearthed a number of differences between what people say or think they do and what actually happens. So this is an example. The standard steroid treatment for high-risk GVHD is a dose of 2 milligrams per kilogram of prednisone equivalent. And the FDA often mandates that this is the dose that's used in clinical trials. This is what physicians actually do from our consortium. So, I mean, anything above about 0.5 mg per kilogram per day is high-dose steroids. But you can see there's this wide range and here. And these are practices that we're able to you can only identify when you have a study like the one that we've been conducting for quite a while now. But let's just dive into the translational trial space. So what are some of the barriers to better outcomes? Well, one is that the clinical symptoms at diagnosis are weak predictors of treatment response and survival. And thus, almost all patients are treated with high-dose steroids. And even as I showed you on that last slide, where there's a wide range in steroid dosing practices, almost all of it was high dose. And this has clinical implications for primary GVHD trials. So one is when you include the low-risk patients who will respond well to steroids, i.e. patients who will do perfectly fine with a placebo, this increases the risk of missing a primary endpoint, requires more patients, and raises the cost of the trial. Likewise, when you're, because we have been unable to identify who the low-risk patients are, it prevents de-escalation trials, and thus a lot of patients are getting overtreated with steroid therapy and experiencing complications that possibly could have been avoided. So Jamie and I recognized that we needed a lab test that can risk stratify patients at the diagnosis of GVHD. So let's think about in terms of developing the lab test, and what do we know about GI GVHD biology? Because that's where the organ, and if it responds well, the patient does well, and if it doesn't respond well, the patient's at much greatest risk for mortality. So we know that there's a strong connection between the GI microbiome and graft-versus-host disease, and this is a figure that I've obtained from a review article in the New England Journal of Medicine by Rob Seisser and Bruce Blazer. So here in this figure, you can see that there's the intestinal lumen on the upper sort of top left corner, and that there's bacteria and other organisms that are normally contained within the intestinal lumen, but because of damage, they're able to translocate. And we see that we could get these DAMPs, or damage-associated molecular pattern molecules, and PAMPs, or pathogen-associated molecular pattern molecules, that traverse into the tissue, and they trigger immune activation and presentation of host antigen to donor T cells, resulting in T cell attack of the host tissue, followed by a cycle of more damage to the intestinal epithelium and more translocation of microbes. And here's some data that actually shows, this is from a study at Memorial Sloan Kettering, that GI dysbiosis is associated with worse outcomes. The worse the dysbiosis, the worse the GVHD outcomes. So the first panel here on the left is just a measure of bacterial diversity. In the column all the way to the far left, labeled no GVHD, we can see that there's a lot of bacteria, a lot of diversity. And then even prior to the onset of GVHD symptoms, you can see that the diversity is shrinking. And even after onset, it's still significantly less diverse compared to the no GVHD controls. And in fact, we can even isolate specific bacterial species that are associated with graft-versus-host disease outcomes. So decreased Clostridia blautia is a very specific species, which is associated with the production of butyrate, which is an essential nutrient for intestinal epithelium health, is associated with more graft-versus-host disease. And that's shown with these cumulative incidents of non-relapse mortality, curves shown here on the right, that when the non-relapse mortality is significantly less in patients who had high butyrate producers within their intestinal lumen compared to patients with low butyrate producers. So how do we take that forward? That's all great about what's going on in the GI microbiome inside the intestinal lumen, but how is that going to help us figure out what to do with patients and give us that lab test that we need? Well, that GI dysbiosis is also associated with an immune activation, is also going to have some changes that we're going to be able to see in the form of proteins. So first, I mentioned then that commensal bacteria such as Clostridium provide butyrate, that energy source used for intestinal epithelial cell repair. And it also induces interleukin-22, and so does indole, and that helps repair the mucosal barrier. IL-22, which is produced by ILC3 cells, induces Paneth cells to secrete antimicrobial peptides, or AMPs, such as defensin and REG3. And AMPs, together with the mucus barrier, protect cells from invading bacteria. REG3 also provides survival signals to intestinal stem cells, and that's essential to the regeneration of the GI tract. And IL-33 promotes ST2 positive regulatory T cells and release of tissue repair proteins such as amphoregulin. Soluble ST2 blocks this favorable interaction. So I've highlighted some of the proteins that I think will end up proving to be the most important as we go forward. So just to summarize, as far bringing things back to GVHD biomarkers, immune activation, dysbiosis, and inflammation that leads to tissue damage. These processes result in changes in serum and plasma concentrations of associated proteins. We can divide them into two broad, somewhat overlapping groups. One is immune activation and inflammation biomarkers associated with GVHD, include tumor necrosis factor 1, TIM3, interleukin-6, interleukin-2 receptor alpha. These are all markers of immune activation. And we also have tissue damage biomarkers associated with GVHD, which include from the GI tract, suppressor of tumorigenesis 2 or ST2, and regenerating islet-derived 3 alpha or REG3 alpha, both of which I just showed you on that previous slide. So we conducted a study. Sorry, I accidentally eliminated a slide. So I'm just going to say it and then we'll get to the results. So we were interested in which of these biomarkers, whether it's the immune activation and inflammation biomarkers, that would be most helpful in determining, would be most prognostic for GVHD outcomes, or whether it be the biomarkers associated with GI tissue damage. And we looked at all 5 of these biomarkers in a training set of nearly 300 patients, and developed using regression modeling techniques. We developed algorithms that use the concentrations of anywhere from 1 to all of the biomarkers, and to try to predict 6-month non-relapse mortality from the onset of GVHD. And then we found that there were 4 algorithms that worked the best, and they were combinations of ST2 and REG3, either with each other or with TNFR1, or there was a combination that in the training set worked well, which was TNFR1 and TIM3 together. So it was either 2 systemic inflammatory biomarkers, a systemic inflammatory biomarker combined with a GI tissue damage biomarker, or 2 GI tissue damage biomarkers. And I apologize for accidentally deleting that slide that explained all of that. But here are the results. So when we look at the 2 biomarkers, ST2 and REG3 alpha, these are both derived directly from damage to the GI tract. We can see that that algorithm can stratify patients into high risk and low risk. And it creates very clear groups with different short and long-term outcomes. So on the left, I'm showing the day 28 response to steroid treatment. And the patients who are high risk by the concentrations of ST2 and REG3 have significantly lower response to treatment. They also have significantly higher non-relapse mortality. There's really these GI biomarkers are not telling us anything about the chance of relapse, so that translates completely into differences in overall survival. We see a different pattern when we look at the systemic inflammatory biomarkers. Those biomarkers are able to create a high risk and low risk strata, the difference is smaller. It's still statistically significant, but there's really no ability for the combination of the two systemic biomarkers to predict longer term outcomes. The non-relapse mortality curves are completely overlapping, and there's no significant difference in overall survival between the high and low risk groups. So what this told us was that, as one might have suspected from everything that I said in the introduction, that is this damage to the GI tract that's driving mortality. And therefore, if you can measure that damage directly with a couple of GI GVHD biomarkers, you can now start to identify patients based on serum protein concentrations who are either more or less likely to respond to steroids and more or less likely to die. And we see this clearly here, that we can identify patients in contrast to what their symptoms may tell us using this biomarker algorithm. So we just look at how the patients presented. Patients who presented with lower GI GVHD had clearly different outcomes when they're risk stratified by this algorithm. There's a 12-fold difference in non-relapse mortality. But when we look at the numbers of patients represented on each curve, 59 high risk and 51 low risk, about half of the patients who presented with GI symptoms are actually low risk, and their non-relapse mortality looks exceedingly low. So these are patients who are probably, even though they have GI symptoms, and a physician would be rightfully concerned what their outcome might be, and maybe want to treat them very aggressively. They could be good candidates for a de-escalation strategy. And then we look at patients who presented just with skin involvement. And we still see a highly significant threefold increased risk of non-relapse mortality in about 20% of the patients who are high risk. And these patients are not good candidates for steroid reduction treatment, and in fact, probably should be getting more intensive therapy. And in fact, most of these patients will go on to develop lower GI GVHD symptoms. They're just not present at the time that you make that first treatment decision, when the patient presented in clinic or was seen in on the inpatient ward with a stereotypical GVHD rash. So to summarize now, the GVHD biomarkers ST2 and reg3 alpha, what we think they're doing is they're quantifying in crypt damage. So we have the immune activation inflammation results in tissue damage. Reg3 alpha is released into the circulation by the damaged GI epithelium. ST2 is released by damaged endothelium and mesenchyme. It's also produced by the effector T cells. We can measure these biomarkers in the serum, and we have now generated that liquid biopsy that quantifies the extent of GI damage. Much of this is occurring in the small bowel, but that's also inaccessible to endoscopic evaluation. So that really sort of precludes the ability to visualize the damage endoscopically. But we have this, now we have a blood test that lets us do the same thing or even better. Okay, so we call these, we created this algorithm, we call it the magic algorithm. It provides a probability or a risk score for patients. We call them the magic algorithm probabilities maps. The maps estimates the probability of 6-month NRM using the formula shown here. And then we created thresholds to create groups of increasing risk for non-relapse mortality. Some of this work was originally done at the University of Michigan when Jamie and I were there. So we termed them the Ann Arbor scores. And here's just data from the last 5 years from the MAGIC collaboration. And you can see that with each increasing Ann Arbor score, there's a steady increase in the risk of non-relapse mortality. That's a test that is currently out for available for people to order in the clinic. So I'm now going to talk about, we've developed this tool for identifying both high risk and low risk patients. And we wanted to now create a treatment strategy that targets patients based on their risk. So for high risk GVHD, we're looking at inhibition of RIP1. What I'm about to show you is preclinical data from Jamie Farrar's laboratory here, and much of this experimental data was generated by Mariana Prada Acosta, postdoc in the lab. I'm a clinician, so I want to be clear that I'm presenting other people's data now. Okay, so what about RIP1? What makes this of interest to us? Well, RIP1 activation leads to cell death. RIP1 under normal conditions is attached to a complex of proteins, a scaffold that's shown here, which integrates with the TNF receptor. And when TNF binds to the TNF receptor under favorable conditions, it leads to NF-kappa B activation and cell survival. However, when the scaffolding is damaged or absent, RIP1 dissociates from its background scaffold, and it can become phosphorylated, and then it becomes RIPK1. And phosphorylated RIPK1 can bind to its partners, and that results in cell death. It can either create a heterodimer with caspase 8 and lead to apoptosis, or it can bind to RIPK3 and lead to necroptosis. The end result of either pathway is the same, which is cell death. So being aware of this pathway, there was interest in whether this was relevant, whether the RIP pathway is relevant in graft-versus-host disease. So the first thing that was done was looking at 24 GI biopsies taken from patients following transplant who had been were being assessed for GVHD. The Lerner score is a pathologic scoring system used to score GI GVHD, and it can range from 0 to 3. And we also looked at, in the collaboration with Genentech, a laboratory there, looked at phospho-RIP1 expression within the GI tract. So you can see on the left, when the Lerner score is 0, the phospho-RIP1 expression was 0, but on the right panel, you can see a lot of the phospho-RIP1 is staining brown. You can see in a setting where the architecture is clearly disrupted, the crypts look lost, the RIP1 expression is actually also high. So in those 24 patients, they were scored as either, we correlated the Lerner score with the phospho-RIP1 score. And these violin plots show that there's a highly significant difference between the groups, with patients with more severe histologic damage also having significantly higher phospho-RIP1 expression. And even in the small number of patients, of just 24 patients, just looking at the non-relapse mortality between the groups, we can see that high RIP1 expression in the tissue is associated with significantly higher non-relapse mortality. So this is one of those cases where you go from the clinic to the bench, and that led to these series of experiments, and I'm gonna walk you through. These are murine transplant models where the mouse gets graft-versus-host disease. So the mice are irradiated with 1,000 centigrade to ablate them, and then they can receive, the recipients can receive the equivalent of a mouse bone marrow transplant, either from a wild type mouse or from a mouse that has been genetically mutated so that it's RIP1 kinase dead. So the mouse cannot cannot create phosphorylated RIPK. So, and these are from the sorry, these are the recipients, not the donors. Excuse me. The donor is either a syngeneic wild type mouse, where there would be no graft-versus-host disease, or the C3H mouse, which is the equivalent of matches what we would consider a matched unrelated donor transplant. In those cases, the recipient will develop graft-versus-host disease that is usually lethal. So the endpoints for this study was analysis of the GI tissue by looking at infiltration into the lamina propria of lymphocytes, and then survival. So in the genetically inactivated mice, they could not, that prevented GI GVHD mortality, and that's shown here. So first we're looking at the tissue infiltration of the T cells from the donor mice. And you can see on the far left, in the syngeneic wild type, or when the recipient is RIP kinase dead recipient, there's no infiltration of T cells, as would be expected. In the wild type into a normal mouse, we see that there's a significant infiltration of CD4 cells that express either interferon gamma or TNF alpha. But in the RIPK dead mouse, there's a significantly less infiltration, suggesting the protective effect from genetic inactivation. And we see the same thing with CD8 cells. And here we have the survival curves. So again, in the syngeneic recipients are shown in the top two curves, and in both cases, they have 100% survival, as would be expected. But we see that in the wild type mouse, 60% mortality, but in the RIPK dead mouse, we can see that the mortality is closer to 10%. So that an inability to activate to phosphorylate RIP1 and to have a partner create those partnerships and heterodimers that result in apoptosis and apoptosis results in much better survival. And these experiments were carried forward into an organoid model. And here we're using a pharmacologic inhibitor of RIPK1. And I'm going to show you, starting at the top left, these are organoids are sort of synthetic in vitro colons or ileums. This is an ileal stem cells. So what we can see here are two things. One is it creates a three-dimensional model of the GI tract. And what we see up on the very top left is what looks like a healthy organoid, and the green is indicating the intestinal stem cells. So in these mice, they've been their intestinal stem cells have green fluorescence protein, so they'll show up as green. And when we give them we create no inflammation by not giving them any TNF alpha or interferon gamma, and they don't get any of the drug, and they have a nice healthy organoid, lots of stem cells. And then when we add the drug alone, the stem cells are unaffected and the organoid remains well. When you just give the inflammatory signaling that mimics what we would see in graft-versus-host disease, the intestinal stem cells are lost and the size of the organoid gets much smaller, but it's able to be restored under those conditions by adding the drug. And one of the, in these in vitro experiments, one of the measures is just the area of the organoids. And you can see that in the inflammatory conditions, the green stem cells are lost and the size of the organoids across the board, those were just representative photomicrographs, is much smaller, but it's restored when a pharmacologic RIP inhibitor is given. And we see this basically the same pattern looking at the mouse colon. And when we look at this in humans, now humans aren't mutated to have green fluorescence protein in their intestinal stem cells, so the outcome of measure is the size of the organoid. We can see again in the human ileum, inflammatory conditions result in much smaller organoids, and the size of the organoids can be restored by giving a pharmacologic RIP1 inhibitor, and we see the same thing in the colon. So I showed you before what happens when the mouse has RIP genetically inactivated, but now we're going to look at what happens when we use this drug GNE 684 that was developed by Genentech, and the experimental model is essentially the same, except none of the mice are mutated. So first, when we look at the infiltration of T cells into the lamina propria, we see that in the syngeneic recipients, there's still no infiltration. Now there's infiltration in the wild type control, but now instead of the genetically mutated mouse, we now are just giving the drug. We see that there's a significant reduction in the infiltration of interferon gamma and TNF alpha producing T cells, both CD4 and CD8. And when we now are doing this in the survival outcome analysis, we can see that the syngeneic mice have excellent survival. The wild type transplant, the allogeneic transplant results in, again, about 60% mortality in the mice. But we also see when we start giving the mice the drug in a prevention strategy, starting at the day of transplant, we see this dose-dependent effect where with higher doses of the drug, survival improves up at the highest dose to 100% survival. And as from a clinical standpoint, we're particularly interested in what can we do from a treatment strategy. So here the treatment is delayed until after the GVHD has been established in the mouse. And we can see that even in that setting, that high dose of the RIP1 inhibitor results in significantly better survival compared to the allogeneic control. And we also looked at whether there might be, could this drug, which we wouldn't expect it to have an effect on graft versus leukemia effect, because we think the primary mechanism of action is protecting the intestinal epithelium. Rather than affecting the T cells directly, we did these experiments to see if there was any loss of the graft versus leukemia effect. So the first thing that you're seeing here is mice are given syngeneic transplants and myeloid leukemia, and all of the mice die from the leukemia within about 3 weeks. This is an expected result in these controls, and giving the drug to the mice did not in any way show any benefit, and the drug didn't exert any anti-leukemia effect. In the allogeneic control experiment, the mice don't die from leukemia, but they die from graft versus host disease. So they get the graft versus leukemia effect, but they also get the fatal GVHD. But when the drug is given, we see now that their survival is improved. So death from graft versus host disease is being reduced, but and not offset by a loss of leukemia control. And the same results were seen using a lymphoid leukemia model. So having established with all of these preclinical experiments that RIP inhibition looks like a very intriguing approach to graft versus host disease, in a collaboration that we're doing with Genentech, we're now taking the human version of this drug. It doesn't yet have a name other than GDC8264. And want to take it forward into clinical trials. So it's an orally administered small molecule. It's a reversible inhibitor of RIP1 kinase, highly potent and specific. It has very favorable non-clinical safety and toxicology studies. And we've designed this trial in this collaboration, this industry academic collaboration, where we're going to treat patients with newly diagnosed high-risk GVHD with a combination of standard steroid therapy and 1 of 2 doses of the study drug. The plan is to treat 40 patients total. Now, I told you all about the biomarkers to identify who those high-risk patients are who might benefit from this approach. And that was our strategy initially, to focus this on those patients with Ann Arbor 2-3, or those who are at high risk of non-relapse mortality from GVHD. However, although we've conducted several other studies that use biomarker risk scores for inclusion criteria, this time the FDA said that for this first study, we needed to take a more traditional approach and include patients based on clinical symptoms alone, at least for this phase 1 portion. So our plan is to treat and randomize 40 patients to these 2 dose levels, and then compare their outcomes to a 3-to-1 control group that we'll obtain from the MAGIC database. And we're going to be doing all of the comparative analysis between the study patients and the controls here at Mount Sinai. So, talked to you a lot now about high-risk GVHD. What can we do for low-risk GVHD? Because that's actually the larger group of patients who are diagnosed with GVHD, and they have complications commonly from long courses of high-dose steroid treatment. So this is data that I'm going to talk about a clinical trial that we ran out of Mount Sinai through the MAGIC Consortium that was just published last month in Blood. So I've told you multiple times now that we use high-dose systemic corticosteroids. And when we look at what the guidelines say from the national bodies, they recommend 20 to 40 milligrams per kilogram of prednisone equivalent in the first month of GVHD treatment alone. And it's not just 1 month of treatment and then stop. Systemic corticosteroid tapers tend to be very slow because physicians are concerned that the patient might flare, even if they've had a complete response. And we studied the impact of systemic corticosteroid therapy on infectious morbidity using the MAGIC database. And here's what we found, that as one would expect, systemic corticosteroids increase serious infections. So when we compare patients who were treated with just topical steroids to those who were systemically treated after controlling for organ severity and biomarker risk score, we found that there's about a twofold difference in the proportion of patients who develop a serious infection. And in fact, the infections are being driven, the differences being primarily driven by differences in viral infections, which makes sense when we think about the mechanism of action of steroids and their effect on lymphocytes. And what we also saw was that not only are there more patients likely to develop at least one infection, that they actually had more serious infections per patient. So the mean was 0.86 in the steroid systemically treated patients compared to 0.36 in the patients who were treated with topical therapy. We also wanted to identify patients who would be eligible for a de-escalation strategy. So a commonly used clinical risk stratification system in transplant is called the Minnesota risk classification. And about 84% of patients are categorized as standard risk by this classification, not low risk, standard risk. That means they have about a 20% 1-year non-relapse mortality. The smaller proportion of patients who are high risk do much worse. They have over 40% non-relapse mortality. But when we apply the Ann Arbor scoring system just to these patients who are at standard risk, we can identify an even lower risk population if they also have Ann Arbor 1. You can see that the day 28 overall response rate is very high in those patients who have both Minnesota standard risk and Ann Arbor 1 GVHD. It's over 50% of all the patients who are treated for GVHD. Their 12-month non-relapse mortality is less than 10%, and their day 28 overall response is 83%. So these patients who are at low risk for non-relapse mortality may not require systemic corticosteroids if there is a safer option. So, but what would that safer option be? And we were interested in JAK inhibitors as to be this sort of non-steroid GVHD treatment. So ruxolitinib is a JAK1/2 inhibitor. It's approved for steroid refractory GVHD. The key side effect of this medication is cytopenias. And in a recent phase 3 clinical trial for initial GVHD treatment, itacitinib, which is a selective JAK1 inhibitor, in combination with systemic corticosteroids, was well tolerated. The cytopenias are primarily due to inhibition of JAK2, which is integral to the hematopoietic growth factors, whereas JAK1 has a lot more to do with the inflammatory pathways, and inhibition of JAK1 inhibits the inflammatory pathways. So in this study, we hypothesized that itacitinib monotherapy would effectively treat low-risk GVHD with less infectious morbidity than systemic corticosteroids and little hematologic toxicity. So we did a multi-center phase 2 trial. The primary endpoint was the day 28 overall response rate. We enrolled 70 patients. And our key inclusion criteria were that the patients could not have previously been treated systemically for GVHD, although topical therapy was okay. They had to be at least 12 years old. They had to be engrafted following the transplant, but we didn't have any other restrictions. They could have had a transplant from any type of donor, any type of stem cell source, any GVHD prophylaxis regimen. We excluded patients who had uncontrolled infections or severe organ dysfunction, chronic GVHD, or who had already relapsed. And we screened patients with Minnesota standard risk. Now, this study was conducted at about 12 centers across the United States. And in order to determine that the patients had not only Minnesota standard risk, but also Ann Arbor 1 GVHD, when they consented the patients, they needed to collect the serum sample and ship it priority overnight to New York so that Dr. Ferrara's lab could score the patients. And if they were Ann Arbor 1, they were eligible to enroll and be treated. And in fact, in all cases, the Ann Arbor score was able to be resulted within 30 hours of shipping the sample or collecting and shipping the sample from the patient. So we were able to show that real-time biomarker scoring was feasible in the context of a clinical trial, crossing the entire continent. So in our study design, the treatment of the endpoints is that patients were given an initial cycle of itacitinib at a dose of 200 milligrams per day for 28 days. And if they responded, they were eligible for a second cycle, but they were not required to receive it. And the primary endpoint was the day 28 overall response rate. But we had secondary endpoints of non-relapse mortality, relapse, chronic GVHD, and overall survival. And we also were interested in the rates of serious infections, in the incidence of new or worsening grade 3 or higher cytopenias, and non-infectious, non-hematologic treatment emergent adverse events up to 90 days after the start of treatment. For this study, we wanted to compare the outcomes to a control group that we generated from the MAGIC database. So we used a 2-to-1 control to case ratio that provided 80% power to identify a 50% reduction in serious infections. And from the database, we, which has thousands of patients, we originally identified a preliminary control pool of 200 patients. Then we matched them to the study patients based prioritizing the target organ involvement, the donor type, the degree of HLA match, and the GVHD prophylaxis regimen that was given. Then we did what we think was a really important step, which is we then retrospectively screened the subjects for study eligibility. And we found that there were 18 patients who would not have met the eligibility criteria for the trial, either because they had an uncontrolled infection or they had severe organ dysfunction or one of the other criteria. So it was about 10%, 9% of the total. But this becomes important because one of the problems when you compare to historical controls is that those patients were almost never determined whether they would have been eligible for the trial. So it's often, control groups often tend to be sicker and less likely to respond to treatment or experience other problems compared to study patients, which tends to make unfairly or bias the results in favor of the study patients in single-arm trials. And we wanted to avoid that in our analyses. So after we had this population of 182 eligible controls and we needed 140, we then did a second matching where we now again rematched to the study population, and we had this final control population of 140 patients. Cases and controls were all matched for all of the above criteria, as well as age, conditioning regimen, the use of ATG or serotherapy to prevent GVHD, the risk for CMV viral reactivation, and their use of topical corticosteroids. So the first thing to show you is that in this low-risk population treated with itacitinib, we saw very few non-infectious grade 3 or higher treatment emergent adverse events. The drug looked very, very safe. And in fact, we saw no grade 4 or 5. When we looked at the primary endpoint, we found that itacitinib was as effective as systemic corticosteroids, both in patients with all presentations of graft-versus-host disease shown on the left, or in patients who had lower GI GVHD symptoms as shown on the right, which, as I've mentioned before, is that lower GI GVHD in which the responses are most important, and steroid refractory disease in that target organ is associated with the greatest risk of mortality. Itacitinib-treated patients were more likely to respond by the 7th day of treatment, 81% versus 66%. The patients who failed itacitinib treatment were able to be salvaged with steroid therapy in 7 out of 8 cases. And there was no differences in the flares through day 90, so 11% versus 12% between cases and controls. And we saw no significant difference in outcomes regardless of target organ involvement or patient transplant or donor characteristics. And importantly, the itacitinib-treated patients received 90% less systemic corticosteroids within the first month because the patients only got steroids if they failed itacitinib treatment. So we were able to show in this analysis that we have evidence that we may be able to completely avoid steroids in the majority of patients if their GVHD is low risk by clinical and biomarker criteria. So when we look into the serious infections, itacitinib actually was better than systemic corticosteroid treatment. So here's just the cumulative incidence of serious infections, and there's about a 40% reduction in the patients who received itacitinib. And when we look at it another way, again, we see that the number of patients with the severe infections is significantly less, and the benefit seems to be in many ways driven by a large reduction in viral reactivations that require treatment. So we saw fewer serious infections per patient. The mean was 0.43 compared to 0.66 in the steroid controls. And importantly, as we had hoped, we didn't see any evidence of that there would be more new or worsening cytopenias with the selective JAK1 inhibition compared to what we see with systemic steroids. In fact, the severe leukopenia was significantly less in the itacitinib treated patients. And when we look at all of those key secondary endpoints, we see that itacitinib was equivalent to systemic corticosteroids. There's no difference in the rate of relapse. There's no difference in the cumulative incidence of chronic GVHD. There was no difference in non-relapse mortality, and there was no significant difference in overall survival. And in every scenario, not only was there no difference, but even when the curves were starting to separate a little bit, that trend in overall survival, it favored itacitinib. So our conclusions from this study was that a short course of up to 2 months of itacitinib monotherapy was as effective as systemic corticosteroids in the treatment of low-risk acute GVHD patients. GVHD flares were rare, and itacitinib treatment failures were salvageable with systemic corticosteroids. Itacitinib monotherapy dramatically decreased steroid exposure. It reduced the rates of serious infections and was well tolerated. And long-term outcomes were excellent for patients treated with itacitinib monotherapy. So we concluded that JAK1 inhibitor monotherapy warrants continued investigation as a safer steroid-free alternative for the majority of patients. And lastly, the combination of clinical and biomarker risk stratification is effective at identifying patients who may benefit from systemic corticosteroid treatment de-escalation or novel GVHD treatment strategies. Then just to summarize the talk in general, GVHD biomarker scores can help personalize acute GVHD treatment for individual patients. Treatment can be intensified for the high-risk patients who need it and de-escalated for low-risk patients. And an emerging theme within MAGIC is our interest in developing non-immunosuppressive treatments for GVHD, such as RIP1 inhibition and or JAK1 inhibition. Well, I'd have to say that JAK inhibition is immunosuppressive, but less so than steroids. They're under development and are promising. And effective treatment that doesn't require high-dose steroids can extend transplant options to older and sicker patients. So I have a lot of acknowledgments to make. I realize now that I'm looking at this slide that I should have included all of the Genentech collaborators, so my apologies for leaving them off. But key people to acknowledge is Rachel Young, who leads the MAGIC Data Coordinating Center. Alexandra Cappellini is a Mount Sinai medical student who worked together with Aaron Etra, an assistant professor in bone marrow transplant, did the analyses for the itacitinib study. Alexandra, I'm happy to report, just matched in Med-Peds at the University of Michigan. And then in the MAGIC lab, that's led by Jamie Ferrara, Mariano Prado Acosta, and Sam Jiang, postdocs in the lab that did analyses all that preclinical data that I showed you, and of course our MAGIC collaborators and our funding source.
Thanks so much, Dr. Levine. That was a wonderful talk. We do have some questions from Dr. Kraft. What is known about IL-33 and GVHD, given that ST2 is a receptor for IL-33? Is soluble ST2 is being released? It may be a decoy receptor.
Yeah, I just wanted to make a comment. Really, really lovely talk. The GI data you showed is intriguing. It has a lot of parallels to the lung. I'm a pulmonologist. And so we see IL-33 being released in the setting of damaged epithelium, which is what you're showing certainly with this dysbiosis. And so don't know if anyone's really looked at the whether IL-33 is actually being released as well, or where that is in the pathophysiology of all this. So thanks again for a great talk.
I haven't seen, at least in the GVHD literature, a lot of data on IL-33 directly. Soluble ST2 is a decoy receptor for IL-33, and acts, I guess, is something of a sink.
Exactly.
Yeah. Maybe Jamie, do you know if IL-33 has been measured? You're muted. You're still muted.
Oh, I don't know if he can unmute himself.
He can't unmute himself. That's a shame. I don't, to the best of my knowledge, and I don't, has IL-33 in humans been measured in the pulmonary literature?
Oh yeah. Yeah, we look at it. Actually, it's not the easiest to measure, but you can look at it in bronchoalveolar lavage and epithelial cultures. And there's actually use of it as a potential anti-IL-33 as a potential therapeutic. There's an antibody out there.
Yeah.
That looks promising. Actually, it's being studied more for COPD these days than asthma, but it had effects in asthma too. So
what about serum concentrations of IL-33?
That, we don't tend to measure a lot of cytokines in serum for some of the reasons that you also mentioned. Is the concentrations are incredibly low and don't always correlate with events going on in the lung. So I would suspect that may be true for the GI tract also.
Yeah, and I guess we don't have sort of that same source, like a bronchoalveolar lavage fluid to measure. I mean, I suppose people have looked at proteins in the stool, especially in diarrhea, like fecal calprotectin and alpha-1 antitrypsin, and they do seem to correlate with events. But it might be really IL-33 just may not be enough, even if it's in the lumen, to
right to have high
measure it.
Jamie's saying that in the chat. Haven't seen any IL-33 serum measurements. Soluble ST2 may bind to IL-33 right as a decoy similar to TNF. Yeah. So very interesting. Thank you.
Yeah. Thanks for the question.
I was actually interested in what gives the RIPK inhibitor such specificity. Is it that it just targets the epithelial cells and protects them, or why doesn't it have effect on the cells?
I think it's more that's the organ of interest where the damage is occurring. This class of drugs is being tested in other diseases that have nothing to do with the GI tract. So like neurodegenerative diseases and some inflammatory and autoimmune skin diseases. So I don't think that the RIP pathway is limited to the GI tract. I think that's what we would be. But that's where the inflammation and the TNF is of interest in patients with graft-versus-host disease.
That makes sense. Also very exciting is the use of these less suppressive JAK inhibitor-like regimens. I think in the context of cancer therapies these days, which are increasingly immune focused, is there any prospect for, I guess, joint utilization of targeted immunotherapy in the context of
well, I think most of the issue with immunotherapies in cancer is more about facilitating recovery from the if you overshoot in terms of immune activation. To date, I think most of those strategies have really been targeting the immune system cells themselves. It's interesting also that that appears to be much more of a systemic issue. So the targeting is not really tissue specific. Thank you.
Yeah.
Okay.
Right. Well,
Thanks very much.
thanks so much.
Sarah, thank you for inviting me.
It's wonderful to see your update. Amazing translational teamwork between the Ferrara lab and yourself, and seeing the implementation of new novel therapies in the clinic. Thanks so much.
Okay, take care. Bye.